subarachnoid hemorrhage, management of subarachnoid hemorrhage in neurosurgical patient. Welcome, Farid. Go on.
Assalamu alaikum, dear colleagues. Good afternoon. Today we are going to discuss management of subarachnoid hemorrhage. Subarachnoid hemorrhage is defined as bleeding into the subarachnoid space within the intracranial fold. Rupture of cerebral aneurysm represents 7 to 85% of the cause of subarachnoid hemorrhage. Other causes like arteriovenous malformations, tumors, and trauma. Arterial supply of the brain by circle of Willis, it lies at the base of the skull. Main components are the 4 major vessels. 2 internal carotid arteries supplies the anterior 2/3 of the brain. 90% of the aneurysms lies in the anterior circulation. 2 vertebral arteries supplying the posterior 1/3 of the brain. Venous drainage of the brain. Cerebellar and cerebral cortices drains into the dural sinuses. Superior sagittal sinus drains into the right transverse sinus. Inferior sagittal sinus drains into the left transverse sinus via the straight sinus. Both transverse sinuses merge into sigmoid sinuses before emerging from the cranium as internal jugular vein. Deeper cranial structures drains into the 2 internal cerebral veins, joining together to form the great vein or vein of Galen, which drains into the inferior sagittal sinuses. Cavernous sinuses drains into the transverse sinuses. The brain receives between 15 to 25% of the cardiac output, with cerebral blood flow 40 to 50 milliliters per 100 grams of brain tissue per minute. Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. Normal range from 60 to 80 millimeter mercury. Predictors of mortality in subarachnoid hemorrhage. The large volume in the CT brain is the best predictor. Level of consciousness on presentation, old age, and comorbidities. Bleeding in the subarachnoid space causes increased ICP to become equal to the systemic arterial pressure, which causes sudden onset of severe headache and loss of consciousness. Blood in the subarachnoid space causing headache, meningism, subsequent development of hydrocephalus, and cerebral vasospasm. Clinical picture of subarachnoid hemorrhage. Sudden onset of severe headache, convulsions, nausea and vomiting, disturbed conscious level, focal and neurological deficits, meningism, and the clinical pictures of complication. في مشكلة تقريبا. في مشكلة
في كويس يا محمد، في حاجة كويس مش كويس.
بس هو البرزنتيشن فيها مش عايزة تشيفت.
باشمهندس أحمد بليز. باشمهندس
مع حضرتك يا دكتور.
هو في مشكلة في البرزنتيشن عند فريد، مش بتبروسيد البرزنتيشن.
طيب احنا ممكن نشير من أول وجديد؟
اوكي
اتفضل.
Okay. Clinical picture of subarachnoid hemorrhage, sudden onset of severe headache, convulsions, nausea and vomiting, disturbed conscious level, focal and neurological deficits, meningism, clinical pictures of complication. Hunt and Hess scale classifies the subarachnoid hemorrhage, grading from 0 to 5, starting from 0, unruptured aneurysm, reaching 5, the patients with deep coma, cerebral rigidity, moribund appearance. Hypertension, diabetes, atherosclerosis, chronic pulmonary disease, or vasospasm assign patient to next less favorable category. The World Federation of Neurosurgeons also classifies subarachnoid hemorrhage into grades from 1 to 5, using the Glasgow scale score and the motor deficit. Investigations required for subarachnoid hemorrhage: non-contrast CT brain, magnetic resonance imaging, magnetic resonance angiography, catheter angiography, lumbar puncture, 3D rotational angiography. Complications of subarachnoid hemorrhage includes rebleeding, cerebral vasospasm, hydrocephalus, cardiovascular dysfunction, electrolyte, and glucose disturbance. Rebleeding is the most serious complication of subarachnoid hemorrhage. Peak of incidence up to 66 to 15% in the first 24 to 48 hours, and 15 to 20% in the first 2 weeks. Management either clipping or endovascular coiling. The aim is to treat all rupture aneurysm within the first 72 hours. Endovascular coiling has less neurological complication in comparison to clipping. However, surgical clipping has low incidence of rebleeding and high success rate of complete aneurysmal occlusion. Cerebral vasospasm. It is the most common cause of mortality, as it affects up to 75% of subarachnoid hemorrhage patients. Peak of incidence at day 7, a range starts from the 3rd to the 14th day. We diagnose cerebral vasospasm by deterioration of conscious level, transcranial Doppler, where the mean velocity more than 140 centimeter per second, or increase in the flow velocity by more than 40 centimeter per second in 24 hours. CT angiography is important in diagnosis of cerebral vasospasm. Prophylaxis of cerebral vasospasm. Nimodipine is 60 milligram every 4 hours for 21 days. And there is no evidence between oral nimodipine, no evidence in the use of oral nimodipine versus IV nimodipine. Magnesium sulfate can be also used in prevention of cerebral vasospasm, as it is a cerebral vasodilator and decreases the incidence of cerebral ischemia, with dose 10 milligram per kg over 30 minutes, followed by continuous infusion of 30 milligram per kg over 24 hours, up to 7 to 14 days. Sedation is very important, as most of patients are anxious, to avoid hypertension, positive fluid balance, avoid hypotension and hyponatremia. Treatment of cerebral vasospasm. Triple H therapy of very low evidence. Hypertension using vasopressors. Target systolic blood pressure in unclipped aneurysm from 120 to 150 millimeter mercury, in clipped aneurysm from 160 to 200 millimeter mercury. Hypervolemia using fluids. Target central venous pressure from 8 to 12 millimeter mercury. Hemodilution to decrease the blood viscosity. Target hematocrit from 30 to 35. Complication of triple H therapy is pulmonary edema, rebleeding, myocardial infarction, reperfusion injury. Balloon angioplasty and papaverine are also used in treatment of vasospasm. Indication of balloon angioplasty: deterioration of neurological functions, unresponsiveness to medical treatment, no infarction distal to the spastic vessel. In its complication is arterial dissection, rupture, and thrombosis. No evidence for the use of antiplatelets in the cerebral vasospasm. Hydrocephalus. It occurs in 15 to 20% of cases, caused by occlusion of the ventricular drainage by blood clots, leading to increase of ICP, diagnosed by CT brain. Treatment: hydrocephalus resolves spontaneously or either by surgical ventricular drainage. Cardiovascular dysfunction occurs due to intense sympathetic stimulation by catecholamines. The patient with subarachnoid hemorrhage may present with systemic and pulmonary hypertension, myocardial infarction, pulmonary edema, or arrhythmia. Investigation required for cardiovascular dysfunction: ECG, troponin, and echocardiography. Electrolyte disturbance and glucose imbalance. Hyponatremia is very common with subarachnoid hemorrhage, either by cerebral salt wasting syndrome or syndrome of inappropriate ADH secretion. Hypomagnesemia, hypokalemia, and hypocalcemia. Hyperglycemia is common in patients with subarachnoid hemorrhage. Perioperative anesthetic management. Preoperative evaluation includes routine labs, correction of electrolyte disturbance. Regarding cardiac condition, cardiac enzymes and echocardiography to exclude myocardial injury. However, in urgent surgeries, consider ECG changes and cardiac symptoms as myocardial injury, as there is no time for good assessment for the or the presence of echocardiography. Underlying cardiac impairment may influence the decision in favor of endovascular occlusion rather than occlusion of the aneurysm. Regarding pre-medication, no drug can be considered the drug of choice in all situations. In anxious patients, a balance should be present between avoiding hypertension and respiratory depression. Nimodipine should be continued. Vasoactive drugs administered to maintain adequate cerebral perfusion pressure to be continued uninterrupted. Monitoring. Standard monitoring plus continuous intra-arterial pressure monitoring, urine output, central venous catheter for guidance of intravascular volume and for injection of potent cardiovascular drugs and mannitol. ICP monitoring indicated in patients who have poor clinical grades, hydrocephalus, patients who require post-operative ICP monitoring. It helps in blood pressure management during induction of anesthesia and in the post-operative management of patients who remain unconscious after surgery. Neurophysiological monitoring, either cortical somatosensory evoked potential used for anterior and posterior cerebral circulation. Brainstem auditory evoked potential used for the posterior circulation. Its advantage is detection of cerebral ischemia, adjustment in surgical techniques or removal or replacement of the vascular clip, hemodynamic management, increasing blood pressure to augment collateral perfusion during temporary or permanent vessel occlusion. However, neurophysiological monitoring has high false positive and false negative predictive value. Jugular venous bulb monitoring, not routinely used as it impedes cerebral venous drainage and causes elevation of ICP. Brain relaxation. Brain relaxation can be done by proper positioning, normoventilation. However, in some cases, mild hyperventilation in critical situation. Adequate oxygenation, mannitol, furosemide, drainage of CSF, either by lumbar, subarachnoid, or ventriculostomy catheter. Conduction of anesthesia. General principle for conduction of anesthesia are control of the transmural pressure gradient of the aneurysm, preservation of adequate cerebral perfusion pressure and oxygen delivery, avoidance of large and sudden swings in the ICP, providing conditions that allow optimal surgical exposure with the least brain retraction, allowing rapid awakening of the patient. Choice of anesthesia. We have to avoid all anesthetic drugs with cerebrovasodilatory potential. Basically, all volatile anesthetics, and we have to use cerebrovasoconstrictive and cerebrodepressant characteristic drugs, mainly the IV anesthetics except ketamine. If somatosensory evoked potential required, we have to use total intravenous anesthesia. Goals of induction of anesthesia. We have to achieve adequate depth of anesthesia, prevention of rupture of the aneurysm, preservation of cerebral oxygenation, prevention of an increase in the ICP. Induce hypotension. Decrease the transmural pressure gradient of the aneurysm and thereby the wall stress of the aneurysm. This may facilitate the preparation and the clipping of the aneurysm and help in control bleeding. However, induced systemic hypotension is no longer used routinely in clipping of the aneurysm. We can induce hypotension by local hypotension. Local hypotension by temporary clipping of the artery feeding the aneurysm. The duration of the temporary occlusion, safe duration time from 2 to 10 minutes, regarding the site of the aneurysm and the age and other comorbidities. During temporary clipping, blood pressure should be maintained at or even slightly above the baseline values to ensure adequate collateral blood flow. Induced hypothermia. Passive cooling usually leads to some degree of hypothermia, as long as it does not interfere with the immediate post-operative extubation and awakening. In giant aneurysm, cardiopulmonary bypass and complete circulatory arrest and profound hypothermia can be performed. Pharmacological brain protection, barbiturate or propofol at the dose result in the EEG burst suppression in some situation, in some periods of the surgery, during difficult section of the aneurysm, before temporary clipping of the blood vessel proximal and distal to the aneurysm. However, no controlled randomized clinical trials exist to demonstrate a cerebral protective effect of anesthetic drug during the surgery for clipping of the aneurysm. Fluid management. In patients without pre-operative symptoms of cerebral vasospasm and the good clinical grades, normovolemia should be maintained until the aneurysm is clipped. In patients with symptomatic pre-operative cerebral vasospasm, volume loaded guided by invasive monitoring and transesophageal echocardiogram monitoring or both. If hypertension had been induced before operation, the mean arterial pressure must be maintained intraoperatively at a comparable level. In this patient, induced hypotension is relatively contraindicated. Papaverine installation after clipping of the aneurysm and before closure of the dura is another attempt at preventing cerebral vasospasm. It may cause mydriasis, facial nerve palsy, signs and symptoms resembling malignant hyperthermia, bradycardia, and hypotension. Intraoperative rupture of rupture aneurysm. It occurs due to sudden increase in the blood pressure, abrupt decrease in the ICP, or surgical manipulation. Goals during the intraoperative rupture of the aneurysm: maintenance of normovolemia, temporary occlusion of the cerebral arteries proximal and distal to the aneurysm. The blood pressure management during rupture of aneurysm is controversial. On one hand, transient decrease in mean arterial pressure to 40 to 50 millimeter mercury decreases wall shear stress, reducing bleeding, facilitates surgical orientation, exposure, and clipping. On the other hand, the presence of clinically relevant blood loss and the combination of hypotension and the hypovolemia may result in profound cerebral ischemia. Regarding recovery after surgery, patients should be responsive to verbal command as soon as possible to allow early neurological assessment and decision regarding diagnostic and therapeutic intervention. 20 to 30% increase in the blood pressure above the preoperative baseline values poses the risk of intracranial hemorrhage and edema. However, in patients with increased risk of cerebral vasospasm, increase from 10 to 20% in the blood pressure above the preoperative baseline values may be of benefit. Patients with preoperative Hunt and His grades 3 or 4 or intraoperative complication shouldn't be extubated immediately after operation. Critically ill patients frequently require intensive post-operative cardiopulmonary and general supportive care. Early tracheostomy should be considered in patients with poor outcome. Anesthetic management for endovascular coiling for ruptured aneurysm. The obvious difference between coiling and the clipping, the location where the intervention is performed, peri-procedure blood loss, the need for brain relaxation. Choice of anesthesia either by general anesthesia, in some center using only sedation to allow monitoring of the patient urological function during the procedure. Finally, please don't forget circle of Willis, rebleeding, vasospasm, intraoperative rupture, aneurysm. Thank you.
Thank you, Farid. It was a wonderful presentation. سامعني؟
أنا سامع حضرتك يا فندم.
I would like to ask you about the use of adenosine to control or to induce short temporary cardiac arrest during clipping of aneurysm. Because some literature talk about this issue.
لا تاني دكتور ناصر.
The use of adenosine. Do you know adenosine?
Yes.
Adenosine, which is a drug used to control heart rate or AF, used in cerebral aneurysm surgery. During clipping aneurysm, it induced very short temporary cardiac arrest for seconds to help in clipping aneurysm.
حاجة أنا قريت عن يعني I read this article about during cerebral, but we unfortunately we don't have adenosine in the centers we are working in.
We don't have an experience in it.
Yes.
Because the shortage of drug, if you have the drug, we will use it. Dr. Majid Salah can, if it is attending, Dr. Majid Salah.
Yes, Dr. Nasser.
What do you think about the use of adenosine by some centers, not in Egypt, to be used to induce very short temporary cardiac arrest during clipping of aneurysm? Would you recommend you have an adenosine?
I think we do have similar action of in some interventional cardiac procedures. Use of adenosine to decrease the blood pressure and use a temporary cardiac arrest. And in the presence of supportive measures like pacemakers and necessary drugs, I think it can be done safely.
Yes, yeah, but we don't have an experience in it in Egypt. In our neurosurgical theater, we don't use it. But if you have,
I use it in interventional cardiology interventions to induce a temporary arrest during insertion of valves or critical situations. So I claim I use this adenosine for this purpose. And of course, if you are supported by pacemakers and drugs, it can be safely used.
When experienced personnel and in a well-equipped place, we can use it. You recommend it?
Yes.
Okay. Thank you, Dr. Majid. Thank you, Farid. Thank you all. Again, I am impressed by the high number of attendants, and I would like to be thank you, Dr. Majid, for this effort. When we meet again, inshallah.
I would like to thank Professor Dr. Nasser Fadel for his effort and this nice day he organized. And I would like to thank all my colleagues, the speakers, for the nice presentations they presented. I would like to thank Dr. Saad Mahdi.